So today, today's webinar is to empower our members on saving lives. The webinar is being sponsored by Disque Foundation. It's a US-based foundation which provides free advanced healthcare education to underserved populations in the US. Hello, can you hear me?
There, I can.
Yes, we can hear you.
Yeah, I can mute everyone. It's just that it, then you have to unmute if you want to speak. So go ahead, you can continue.
I can hear you.
Did you want to continue introducing or do you want me to get started? All right, well, I will continue while we work this out. So welcome. Like they mentioned, I work for the Disque Foundation and I have a master's degree in nursing and I have been teaching since I got my master's degree. So I have taught, I live in Maryland, which is right outside Washington, DC, and we're lucky enough to have some world-class hospitals near us. So I've been able to work at University of Maryland, where shock trauma is located, and also at Johns Hopkins University. Oops.
Kim, are you
Okay,
there?
hello,
We
Kim.
can hear you.
Yes, I'm here.
Okay.
Okay, because
All
we
right.
can't hear you again. Good evening,
All right.
Kim.
Okay. Okay. Good evening, everybody. Okay, we'll just go straight because we don't really have much
Mr.
time.
Funle, good evening.
Yeah. Good evening. Good evening, Alex. Thanks for the introduction.
Yeah, good evening.
We wouldn't want to waste too much of time. We just want to dive straight into the CPR training so that we can have many more questions from Kim and get a lot of benefit from this CPR training. We just have less than 45 minutes to do it. So I will just want her to give her the floor now and just take over. Then when it is 5 minutes to the end of the training, then she will complete. Then we can ask our questions. Thank you. Kim, over to you.
Thank you so much. I'm going to switch over to my PowerPoint, and I'm excited to share this with you today. We are going to talk about BLS, and I was asked to include a little bit about trauma and gunshot wounds, so I can do that also. So it's called the Save a Life Initiative, the part of this foundation that allows me to provide free healthcare to others. So that's my job with this company, is I get to teach CPR and other healthcare topics anywhere around the world, anybody that asks, and we get the funding to do that. So that's great. So like I said, today we're going to look at BLS. And these are the components of basic life support. So this is with the understanding that you already have your CPR certification and you're going to be working on basic life support, or you already have your BLS certification and you just want to get a review. So we start with immediately recognizing an emergency. That's our job as healthcare providers. So if we're in a room, whether it's in the hospital or out in the public, we would be the ones that would be able to step up and recognize that something's wrong. We're going to be systematic in our assessment, and we're going to review the components of the assessment. And it's with an understanding that we're performing high quality CPR. So it's something we have already practiced and are very comfortable with. We're using an AED or cardiac monitor and delivering shocks when instructed to do so, and also using effective ventilation. So putting in airways, using bag valve mask, CPR mask, whatever is appropriate for the situation. And finally, BLS includes a component of teamwork. So we will look at communication and teamwork for our BLS. So for the rapid assessment, we're going to conduct a quick visual survey. So that's walking into the room and seeing that the patient doesn't look normal or good or like they did the last time you saw them an hour ago, just noticing that something's wrong, or if somebody collapses, of course, or just figuring out what the situation is. Is it one patient? Is it 3 people? Did you come across, a car accident or a building collapse or something like that? So just taking that all in and being able to sum it up in a few seconds, checking for safety while we're doing that. And then we're going to start by checking for responsiveness. That's where we tap and shout, "Hey, are you okay?" Activating our emergency response system, which would be, here in the US, we're going to call 911, but we're in the hospital. We're going to have different ways to do that. So maybe having texting or calls or paging, or there's a code button on the wall. So there's just different ways that facilities do that. So we want to, of course, know what is the correct way in the area that we're in. Sometimes even in hospitals I've been in, it's done a different way in a critical care unit. And then in the regular med-surg unit, it's, you have to call someone. After we call for help, we're going to open the airway and check for breathing and pulse simultaneously. So that's checking the carotid pulse and checking for breathing, making sure it's not just agonal breaths, but that we have regular breathing. And if we don't, we're going to start CPR. So we're going to take a look a little bit more in depth on these steps. So I am hitting mute on everyone, and then you can unmute yourself, but that would be just for a speaker. If you need to interrupt me for something, or at the end when we do questions, we can ask those directly. There we go. So we're going to do the rapid assessment, and this is someone coming into the room and seeing that their patient does not look well. The color is off. So you're looking for safety while you're doing this, just making sure there's no violence or, anything going on that you wouldn't be able to come in and help them, and getting that quick initial impression.
Hi, Kim.
Yes.
I'm seeing some comments now that they cannot hear you.
Okay.
I'm seeing some comments that they cannot hear you. Is there anything we can do to make
it
that
might be
better?
the problem of their own speaker,
Yeah,
because we can hear very well.
If one person,
Okay, because
then
I can hear you loud. I can hear you loud and clear.
Maybe it will be from their own end.
yes, they have.
I
Okay.
can,
All right.
I can hear very well.
louder.
Yeah, they
Okay,
have.
can
you can
hear
go
loud
ahead.
and clear.
Okay,
You can mute everybody and go ahead.
okay. Yeah, if you are having trouble hearing, that would be on your own device or computer. So you need to make sure the volume is up. Also, that's in the Zoom bar itself. There's a mute and a video button. So just make sure your settings are correct on that. So going back to here, we're gonna tap and shout and say, hey, are you okay? And next is checking that airway for breathing and checking that carotid pulse. So all of that takes 5 to 10 seconds. So we're going to watch this little video on that.
When it comes to being effective in an emergency, rapid assessment skills are crucial. First, conduct a quick visual survey. In any emergency, you need to first make sure the environment is safe for you, your team, and anyone else here. When assessing for safety, ask yourself, are any immediate dangers present? What guidance needs to be given to family members who may be present? Next, form your initial impression of the patient. Remember, the initial impression is about suspicion. Ask yourself, does the patient look sick or unresponsive? Does the patient's skin appear pale, mottled, or cyanotic? Do they appear to be breathing? Is there severe, life-threatening bleeding? If there is, immediately stop it with any resources you have available. Then, quickly determine what additional resources are needed. Who is available to help? Do you need any additional equipment, such as an AED? Once you've finished your visual survey, check for responsiveness. This may be obvious from your initial impression. For example, the patient may be able to speak to you, or they may be moaning, crying, or moving around. If they are responsive, obtain consent and provide care as appropriate. However, if the patient appears unresponsive, follow the shout, tap, shout sequence. Are you okay? Mrs. Jones, are you okay? Observe for the patient's response to the stimulus. It may be subtle, some slight movement or momentary eye opening. If the patient is unresponsive, shout for somebody to activate the emergency response system and get an AED if you have not already done so. Next, make sure the unresponsive patient is face up. If they are face down, you must roll them onto their back, taking care not to create or worsen a suspected injury. Then, open the airway using the head tilt chin lift technique. Or use a modified jaw thrust maneuver if a head, neck, or spinal injury is suspected. Simultaneously check for breathing and a carotid pulse for at least 5 seconds, but no more than 10. 1 1,000, 2 1,000, 3 1,000, 4 1,000, 5 1,000, 6 1,000, 7 1,000, 8 1,000, 9 1,000, 10. Let's break it down now. When you check for breathing, look to see if the patient's chest is rising and falling. Also, listen for escaping air and feel for breathing against the side of your cheek. When you're checking the pulse of an adult patient, palpate the carotid artery by sliding 2 fingers into the groove of the patient's neck. Be careful not to reach across the neck and obstruct the airway. Then, provide care based on the conditions found.
All right, so let me switch back. And we are at 100 right now. My Zoom just holds 100. So we are gonna finish up with that assessment part. So those are the steps for that. And we're gonna do our CPR review now. We'll look at the chest compressions, the airway and ventilations, and also a little bit about AED. The ratio for adults is 30:2 if we're doing the rescue breaths. We will, for children, we can start with 30:2 by ourselves and then switch to 15:2 once other providers arrive, which is hopefully right away. And then if we are doing bag valve mask instead of that ratio, we can do continuous, just every 5 to 6 seconds for adults, every 2 to 3 seconds for children and infants, and just do continuous chest compressions. And then that we're going to be switching every 2 minutes. So you're going to look at our components of high quality CPR. Which is starting with within 10 seconds.
High-quality CPR is the foundation of every successful cardiac arrest resuscitation. To provide high-quality CPR, remember these key actions. First, ensure the patient is positioned appropriately on a firm, flat surface and the chest is exposed, and then immediately begin chest compressions. Provide compressions at the proper rate and depth. At the proper rate, 100 to 120 compressions per minute, it should take you 15 to 18 seconds to complete 30 compressions. Compress the chest to a depth of at least 2 inches, 5 centimeters, but no more than 2.4 inches, 6 centimeters. Let the chest recoil fully after each compression. Don't lean on the patient's chest at the top of the compression. This impedes venous return and prevents the heart from filling completely, which decreases cardiac output. Minimize interruptions to chest. When compressions stop, blood flow to vital organs stops. After stopping compressions, it takes time to regain the minimum coronary perfusion pressure, or CPP, needed to achieve return of spontaneous circulation, or ROSC. The CPP is a reflection of myocardial blood flow. It's the difference between the pressure in the aorta and the pressure in the right atrium during diastole. Maintaining a CPP greater than 20 millimeters of mercury has been shown to increase the likelihood of ROSC and survival. Finally, avoid excessive ventilations. Each ventilation should last about 1 second and deliver just enough volume to make the chest begin to rise. Excessive ventilations can increase the intrathoracic pressure. This can lead to decreased venous return, decreased cardiac output, and a decreased likelihood of ROSC. Excessive ventilations can also cause gastric insufflation, which can lead to regurgitation and aspiration.
So the components of the high quality CPR are performing chest compressions, doing the ventilations with a pocket mask or a bag valve mask, or starting with the pocket mask and then switching to bag valve mask once it arrives. You would start as a single provider, and then once the next person arrives, you would continue as another multiple provider. So again, we're doing ventilations with a pocket mask. That would be 2 ventilations that last about 1 second each and make the chest rise. We need to have the airway open during this time also. If the chest doesn't rise after the first ventilation, we're going to just check everything, reopen the airway, tipping the head back and opening it again, making the seal again, just repositioning everything and trying the second ventilation. If the second ventilation doesn't work, we just continue back with chest compressions and assume there's an obstruction at this point. So we have different types of breathing barriers: the pocket mask, the bag valve mask, and even a face shield, which is basically like a piece of plastic that has a filter in it. So in a facility, we should definitely have our pocket masks and bag valve masks available. We're not going to look at mouth to mouth. Ventilations, we really don't recommend that. That would only be on a loved one. So We're going to look at our ventilations with the pocket mask and the bag valve mask.
For adults, each CPR cycle consists of 30 chest compressions followed by 2 ventilations. Remember to smoothly transition between compressions and ventilations to minimize the interruptions in compressions to less than 10 seconds. Here's what a cycle looks like with one provider. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10. Unlike a pocket mask, a BVM delivers ambient air, allowing the patient to receive a higher concentration of oxygen. If local protocols allow, supplemental oxygen should be attached to the BVM as soon as appropriate and when enough resources are available. Doing so can increase the oxygen concentration to approximately 90 to 100%. When you're the only provider present to operate the BVM, follow these steps. First, select an appropriately sized BVM. Then, if necessary, assemble the BVM. Next, position yourself behind the patient's head in a cephalic position. Place the mask at the bridge of the nose and lower it over the nose, mouth, and chin. The mask should not extend past the patient's chin. To hold the mask in place, position one hand around the mask, forming a C with the thumb and index finger, and an E with the last 3 fingers. This is the EC hand position. Then, seal the mask completely around the patient's mouth and nose by lifting the jaw into the mask. Be sure to maintain an open airway in the pass neutral position. Depress the bag about halfway to deliver a volume of 400 to 700 milliliters. Provide smooth, effortless ventilations that last about 1 second and begin to make the chest rise. Remember, ventilations that are too fast or have too much volume can be dangerous. Although a single provider often uses a BVM, evidence shows that 2 providers are needed to most effectively operate the equipment. I'll maintain an open airway and seal the mask using an EC hand position with both hands, like this.
And while Greg is doing that, I'll deliver ventilations by gently squeezing the bag about halfway to make the chest begin to rise, like this. Each ventilation should last about 1 second.
16, 17, 18.
Now let's watch as the team performs CPR already in progress.
25, 26, 27, 28, 29, 30. 1 and 2.
Switch positions about every 2 minutes, which should take no more than 10 seconds. The compressor calls for a position change by saying switch in place of the number 1 in the compression cycle, as Greg will show you.
25, 26, 27, 28, 29, 30. Switch and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
One and 2 and 3 and 4 and 5.
As with any patient in cardiac arrest, if a patient shows obvious sign of life, stop CPR and monitor the airway, breathing, and pulse.
2, 3, 4, 25, 26, 27, 28, 29, 30. 1, 2, 3, 4, 5, 6, 8, 9, 10, 12, 13, 14, 15, 16, 17, 18.
Stop CPR. I see movement.
I'll check for pulse and respiration. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000.
Okay, I'm going to find the AED section for you next. So AED stands for Automated External Defibrillator. And these are used to shock 2 of our rhythms. We have around 15 to 18 cardiac rhythms, and we can only shock 2, our VFib and our VTAC. So we can take a look at this. Is it safe to use when caring for a woman who is pregnant? Yes. So we just have to make sure that we're putting the paddles not directly on the uterus, but up on the ribs. So kind of on the side, which should be on the ribs anyway, but we just have to make extra sure if someone's pregnant. Yes, cardiac arrest. So it doesn't matter if it's, trauma or not, we need to be using our AED. You should not use an AED if they have a pacemaker or an AICD. And that one is false. If they have the AICD specifically, because that will shock people. That's what that device is for somebody that goes into VFib or VTAC a lot. But if it's not working, it's not working. And that's rare, but that can happen. So, we can definitely still use an AED. When people have the pacemaker, they have a little, battery pack under their skin that looks like a port. So it's kind of making their skin stick out. It's usually on the left side. So we just, again, are not putting the pads on top of that, but our pads should be on the top right and on the left side. It is possible that someone with one of these devices already had something there, or there was, a reason they couldn't put it there. So their pacemaker is on the right. Excuse me. So we just have to make sure we're not putting the pad right on top of it. Should you remove a transdermal patch before using an AED? Yes, but of course we need to have gloves on so you're not touching any of that medication. How about a great deal of chest hair? Yes, we do need to remove that because the pads won't stick. They'll kind of float on top if we have chest hair. So there is a razor in all the kits that I've seen, gloves and a razor, gauze, things like that, scissors.
I'll flog you again. I'll flog you.
Should we remove the jewelry? We don't need to remove jewelry. Again, if it's in the way, I'm going to if there's like a lot of loose necklaces or decorations, I'm going to try to move them out of the way. We don't have time to take them off or anything. And then if there would be any piercings or anything metal that's permanent that we can't move, we're just, again, not putting the pads on them. Can you use it around flammable items such as oxygen? No. So if we are using bag valve mask and I'm squeezing, I need to turn that away from the oxygen, turn the oxygen away from the body when I'm using a defibrillator. about metal surface. And it's false that you should not use it. So that means you are allowed to use it if someone's on metal. So if they were on like a table or a dock, you could still use it. How about a large puddle of water? Kind of depends what you call large. They can be wet, but we're not going to shock someone that's in a body of water. So if it's, you're in a flood or you're pulling them out of a lake or ocean or pool or whatever, we need to get a little bit drier, at least dry off the chest before we use the AED. Also with inclement weather, that's, like I said, okay, so it can be raining or snowing. They can be a little bit wet, but you just don't want it like in standing water.
When a patient is in cardiac arrest, use an AED as soon as it's available. Early use of an AED greatly increases the patient's chance of survival. For each minute CPR and defibrillation are delayed, a patient's chance of survival decreases by 7 to 10%. Since I have an AED with me, I'll use it right away. But if I didn't have one with me, I'd send someone to go get an AED while beginning CPR immediately. And if I had no way of calling for help, I'd put the patient in the recovery position and go get the AED. First, turn on the AED and follow the prompts.
Adult pads. Attach defib pads to patient's bare chest.
Then expose the chest and apply the pads. Use adult pads for adults and children over the age of 8 or weighing 55 pounds. Place one pad on the upper right chest, below the right clavicle, and to the right of the sternum. The pad has a feedback device. Make sure it's placed in the center of the chest. Then place the other pad on the left side of the chest, along the mid-axillary line, a few inches below the left armpit.
Adult pads. Don't touch patient. Analyzing.
To ensure an accurate analysis, instruct everyone to stand clear while the AED is analyzing. Clear.
Shock advised. Don't touch patient. Press flashing shock button.
Press the shock button to deliver the shock. Clear.
Shock delivered. Start CPR.
1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One and 2 and Now we'll show you what to do when there are multiple providers. Karan and Valerie will continue CPR while I operate the AED. This minimizes interruptions of CPR. I have the AED.
Adult pads. Attach defib pads to patient's bare chest.
Do you want to switch on the analysis?
Yes. 1, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Adult pads. Don't touch patient. Analyzing.
Clear.
No shock advised. Start CPR.
While the AED analyzed, we switched positions. Joanne hovered a few inches above the chest, ready to resume compressions as soon as the AED prompted no shock advised. To minimize interruptions,
22.
we'll switch roles like this each time the AED analyzes the heart rhythm.
9:30. 1, 2, and 3.
All right, so now we're going to look at the teamwork part of this. So let me go back to our list. So hopefully you got to see each of these components. We had the chest compressions, the depth, how far down you're pushing by the age or size of the person, minimizing interruptions and allowing complete chest recoil. We looked at some of the rescue breaths, doing a head tilt chin lift, where we're tipping that head back. You would do a jaw thrust if you suspect head, neck, or spinal injury, which is just trying to pull the jaw forward and not moving the neck around at all. But we're trying to get the trachea, that neck airway open and flat. And let's see, we talked about doing every 5 to 6 seconds for adults, every 2-3 seconds for pediatrics if you have a bag valve mask. And then the AED, if you have that kind, the portable kind, you're just going to turn it on and attach the pads and follow the directions. It will only tell you to shock if it analyzes that it has VFib or VTAC. If it says no shock advised, that could be asystole, it could be normal sinus rhythm. It's not telling you anything else other than just VFib or VTAC. So if you're not using AED and you have cardiac monitor, that's also not telling you what rhythm, but you're analyzing the rhythm yourself. So let's look at our communication tips. We use closed loop communication. That's the opposite of open-ended communication. Open-ended is me saying, hi, how are you? How was your evening? What did you have for dinner last night? So those are things that can have any answer at all. The person who's answering can choose what they want to say. That's open-ended question. So for closed loop communication, loop meaning a circle, and closed meaning I know what they're going to say and they're going to say it back and we're just going to confirm and go back and forth. So this is almost like reading a script when you do run a code, because if I'm the leader and I'm saying, what is the rhythm? You know, I'm only going to hear certain answers. I'm not going to hear about their dinner last night. I'm just going to hear we're in VFib or VTAC, or we have a rhythm, or asystole. There's not a lot of choices there. If we get a rhythm back, then you just have to look at that and treat that if it's not normal sinus rhythm. So that kind of goes a different direction. Also, closed loop is used for anything that we would need. So if we're switching compressors, I'm just saying switch at the analysis. I'm not asking a question, it's more of a command. And the person who is next in line to do compressions is going to say confirmed or received, or just some acknowledgement that, okay, yes, I will switch with you at the analysis, but we're just not using a lot of words, just 1 or 2 words. Also, if I need medications, if I'm getting into ACLS, that type of thing, I would say I need 1 milligram of epi, and the nurse who's going to be in charge of that would say, you know, received, you know, giving 1 milligram of epi now, and then you can even confirm it again after you give it and say 1 milligram of epi given, flushed with saline. Everyone has a defined role, and when you find someone down, you are in charge until a set person comes in that we've already decided is the leader ahead of time. So if I'm an RN and my patient goes down, and I work in the ICU or ER or 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 something like that, like I can start that code by myself, and I'm going to start with the assessment, but then I'm going to start compressions. The next people coming in are going to start ventilations and hooking up the AED pads around me or the cardiac monitor. And then whoever is the leader, whether it's a charge nurse or an ER physician or just whoever it is that we've decided ahead of time, once they get there, they could be right there, or they might have to be coming from another unit. But once they get there, I can pass that leadership to them. Like I know that they're the leader. And once they get there, I can just briefly fill them in and say, we've just done 2 rounds, which means 2 minutes each of compressions. The AED has not told us to shock. No shocks have been given. And that's where we are. You know, we haven't done anything else. And then they can take over, and if they want to do something different, they can. I would still be a compressor, or I would switch with somebody, and then the nurse can be assisting with ventilations. We can be running the cardiac monitor. We can be giving the meds. We can do any of these jobs. So you can switch around and decide ahead of time which ones you want to be. And then it's nice when you have new people or nursing students or you're precepting, you know, give them some of the smaller jobs or the observing jobs, like documenting or running to get things or helping draw up meds, so that they can be a part of it also. All right, so then looking at back at the Red Cross part for teamwork. So we're just repeating this again, rapid assessment, and then doing our high quality CPR using the AED. First provider performs the rapid assessment and initiates CPR starting with chest compressions. And then as other people arrive, they are setting up everything around that person who's still doing compressions. So again, we're always looking for high quality CPR. I liked in their video, their AED. I haven't used one like that. The ones I've used are always 2 separate pads on 2 separate wires, so you can kind of put them anywhere. But that one was interesting because it had a center part to it, which there wasn't any electricity going through that, but it was more like a marker, and they're putting it right on the sternum. So then it kind of still gives you this marker for where you're going to do your compressions. I've also seen just in videos, pictures of ones that are one connected thing. So it's like the top part and then the middle part for compressions, and then the one pad that goes over the rib. So it's kind of like you're just putting it on the top of them as a big sticker. And so it's, you know, helping people to just get everything in the right place so that they're not doing it wrong. So we're going for high performance team. Yes, so I've been in codes where we've had 10 or 20 people and the code has lasted for 3 hours because the person was young and it was something that we were trying to fix. It was a surgical problem. And so, you know, their pulse keeps, you know, going in and out. Like you have them, you lose them, you have them, you lose them. Or you could be doing a code with just 2 or 3 people and just don't have the resources. So sometimes you can do a small role and sometimes you have to do more than one thing. You're doing compressions and then you're also, you know, doing the cardiac monitoring. And we do now have ways to monitor our CPR through electronics. So that's kind of nice too.
Even at its best, CPR provides only a fraction of the normal blood flow to vital organs. To increase the likelihood of ROSC and optimize patient outcomes, providers must strive to provide the highest quality CPR at all times. Collecting and analyzing data is key to improving performance, both in the moment and during future resuscitation efforts. Observation is an important qualitative measure of high-quality CPR. The team leader is responsible for monitoring team performance and making adjustments as needed to ensure that high-quality CPR is being provided.
Carolyn, call a code. Joanne, can you get the AED?
I'll get the AED.
The team leader directs the team to perform actions in a way that minimizes interruptions to chest compressions, monitors for proper compression rate and depth, chest recoil, and for signs of compressor fatigue, and observes for proper ventilation rate and volume. Coordinated, efficient teamwork promotes high-quality CPR by minimizing interruptions to chest compressions and maintaining quality compressions. Providers should switch off giving compressions every 2 minutes or sooner if the compressor is fatigued. Feedback devices are designed to act as virtual coaches, guiding providers to adjust technique to perform effective, high-quality CPR. In addition, most feedback devices record data that can be analyzed after the resuscitation event. The chest compression fraction, or CCF, is an important indicator of CPR quality. The CCF represents the percentage of time during the resuscitation effort that is spent performing compressions. It's calculated by dividing the time that providers spend delivering compressions by the total duration of the resuscitation event, beginning with the arrival of the resuscitation team and ending with achievement of ROSC, or cessation of CPR. Strive for a CCF of 80%. At least 60% is the minimum needed to promote improved outcomes. Physiologic parameters also provide objective performance data. Capnography, which measures the end-tidal carbon dioxide level, is a non-invasive way of obtaining an objective measure of ventilation and compression quality with every ventilation. Carbon dioxide delivery to the lungs depends on cardiac output. When circulation is adequate, a predictable amount of carbon dioxide should be exhaled. So, the end-tidal carbon dioxide level is a quantitative measure of cardiac output and, by extension, the effectiveness of compressions. End-tidal carbon dioxide levels in the expected range also indicate that ventilations are effective. There are a couple different ways to measure the end-tidal carbon dioxide level. An adapter can be attached to a BVM, or advanced airway, or a nasal cannula can be applied under a mask. Normally, end-tidal carbon dioxide levels are in the range of 35 to 45 millimeters of mercury. But in low perfusion states, such as cardiac arrest, the levels are much lower. When high-quality CPR is provided, end-tidal carbon dioxide levels should be in the range of 15 to 20 millimeters of mercury. If the levels fall below 10 millimeters of mercury, there could be a problem with the rate or quality of compressions. On the other hand, a sudden spike in end-tidal carbon dioxide levels is often the first sign of ROSC.